Welcome. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'm moderating today's webinar. Today, we'll learn about EoE treatment patterns and persistence from Dr. David Katzka. Dr. Katzka is an attending physician in the Department of Medicine Gastroenterology at New York Presbyterian Hospital, Columbia campus. And he's a professor of medicine at Columbia University Irving Medical Center. His research interests include eosinophilic esophagitis, esophageal motility disorders, gastroesophageal reflux, Barrett's esophagus, and unusual esophageal diseases. Welcome.
Thank you so much, Jennifer, and thank you all for attending. I'm very grateful to be able to talk to all of you today and see if I can provide some information about EoE, which may help you and your families all in treating and understanding this disease. What I'd like to do today is really go over some of the recent advances, I think, and as well as some of my takes on this disease, and cover a paper we recently published on the journey of EoE to some degree and what we can do to enhance care. So I'm going to share my screen now. Okay, so what I'd like to do in discussing EoE and the management are define a few steps. The first is defining your endpoint of treatment. And a lot has changed as far as what we consider remission now compared to what we used to treat before to say patients are under good control. We want to assess the type and severity of the EoE. Whereas for years we've sort of looked at one size fits all, we're now starting to understand there are different subtypes of EoE, if you will, and each of them may require a different treatment. And then we want to discuss the treatment options, what's available for us today, and how can we use these optimally to get eosinophilic esophagitis under control. So first, a little bit of background. That, of course, is knowing that this is continually rising in the United States. If we look at this recent study from Thel et al., we know that the rise continues over time. And you can see from 2009 to 2022. And we know as well that this increase is far beyond physician recognition, as well as the number of endoscopies we're doing. In other words, this is truly a problem which is increasing, and we never really had it before. And what the biology behind seeing this disease increase so much is unclear. There are a lot of theories behind it, which range from global warming to some of the additives we put in foods. We can discuss that another time, but no doubt this is becoming a much more common disease in time. We also know that the most common ages for this are late teenage years and, interestingly, 30s and 40s. And compared to a lot of other allergic diseases, which tend to occur when patients are young, this is more a young and middle-aged disease, and we'll discuss why that is. And finally, we know that this is a very expensive disease. And if you look at calculations of how much this will cost annually in the United States, we're now over $1.3 billion to care for patients with eosinophilic esophagitis. So from a rare disease, say 20 years ago, this is a very mainstream and common disease for us in the United States. One of the big changes in this disease is looking at the eosinophil. And this is a biopsy from someone with EoE, and all these red cells here, which are stained densely red, these are eosinophils. And this is a piece of the lining of the esophagus loaded with these eosinophils, hence the name eosinophilic esophagitis. And this is just a close-up of some of these cells. And for many, many years, we always assumed that this was the important part of the disease. And when we measure disease activity, as you know well, we would count the number of eosinophils on the biopsy, which we still do, of course, and decide, well, this patient's doing well because the eosinophil count is low, or this patient's not doing well because the eosinophil count is high. And some would say, well, what does it mean going from 70 to 20 in the top of the esophagus versus the bottom of the esophagus? But now we know that it's a bit more complicated. And it's a bit more complicated because although the eosinophil still remains important, we realize it's only a partial explanation. It's a player in the EoE, but it's not the whole cause. Part of it, too, also goes along with the fact that if we look at endoscopy and the findings we see on endoscopy, oftentimes when we see severe disease on endoscopy, it doesn't correlate well with the eosinophil count. When we look at patients with symptoms, oftentimes they can have persistent symptoms, yet the eosinophil count may be under great control, and vice versa. And similarly, if you look at a biopsy, there's often a lot more going on looking at that biopsy, other findings besides the eosinophil count. So now when we think about the endpoint of what we want to occur with treatment of this disease, it's not just that eosinophil count. We want to see that the endoscopy looks better. We want to see that all aspects of the biopsy look better. And we want to see that, of course, patient symptoms are better. As a result, now we don't take so seriously or as seriously what that count is. So we may have patients who have so-called normal counts, yet if it's abnormal in other spots, we may treat more aggressively. But conversely, we may have patients who are asymptomatic, their endoscopy looks great, and even if the count is a little high, we may not treat it as aggressively as we used to before. So the eosinophil still remains important, but it's not as pivotal to understanding and treating this disease as we thought for many, many years. So how do we measure this disease? So people have come up with important scoring systems. This one from Evan Dillon. And what these scoring systems do is they measure all aspects of the disease. So they measure the symptoms, and they measure the endoscopic findings, and they divide that in terms of findings that are inflammation versus scarring, and we categorize it into active, inactive, mild, and moderate based on the scoring system. So looking at this closely, we divide symptoms into several categories. So even though we have none weekly, daily, and multiple times per day, we have other things that are important, such as did a food impaction occur? Did hospitalization occur? Heaven forbid, did perforation occur? And these are all things that add a lot of points. So the idea of just asking someone, is your swallowing better or not, is far too simple now. We really have to explore this symptom further. And you know as well as I that oftentimes patients with EoE will do things to make sure they don't have trouble swallowing, like chewing carefully, eating more slowly, drinking a lot of water with their meals, etc. So that just asking, are you having trouble swallowing alone, is by no means a good enough way to judge how patients are doing. Similarly, when we look at endoscopy and we look at the lining of the esophagus, there are many findings we look for in addition to what that eosinophil count is, and so on and so forth. And the important message of this is that to see a doctor or a care provider now and assess whether the patient is doing better or not is not so simple as saying the endoscopy looks better, the EO count is down, and the symptoms are good. The doctors really need to be much more precise in terms of measuring multiple aspects of the eosinophilic esophagitis to really decide if a patient is in remission or not. So I really encourage you to have your care providers do this, as well as to give your care provider as much information as you can, particularly those accommodating symptoms we just talked about. It's fine not to have dysphagia, but if it comes to the price of avoiding all meats and raw vegetables, well, I'm not sure that's really remission. Similarly, we need to talk about heartburn as well as other symptoms as well. So we need and establish a much more comprehensive way of deciding, are patients where they need to be after treatment. The second aspect I referred to before is guidance by phenotype or severity. And when we talk about phenotype, what we're trying to do is take that basket of eosinophilic esophagitis and figure out, are there certain types within that general category that help us choose one therapy over another. And this is very similar to any other disease, such as asthma, where you may have asthma which is triggered by allergic problems versus exercise, or inflammatory bowel disease, where some may involve this part of the GI tract and others. And the importance of this is that some respond differently than others. So we're starting to get some insight in terms of what are those subtypes, those different variations of EoE that help us get treatment that is more specific for that patient. For example, this is a patient with eosinophilic esophagitis who have what we call small caliber esophagus. This is an X-ray of a patient's esophagus. You can see the ribs here. This is the mouth up here and the stomach here. And what you'll notice here is the barium coming down here. And what's noticeable about this X-ray, is that the diameter here is very small. The normal esophagus should be about 2 times to 3 times this size. So this is someone who's had EoE for a long time, such that their whole esophagus is scarred down now and narrow. This is obviously a severe form of eosinophilic esophagitis. And this is a complicated slide, but the message is that investigators such as these from the Northwestern group are now looking at various parameters, such as, does the esophagus distend well? What's the motility like? Is peristalsis weak or normal? And taking all these patterns, combining them to say, this person may respond to steroids, this person may not. And so that's the progress in the direction we're trying to go in. And so with some of these studies can we predict before we even start any therapy how a patient is going to respond? So for example, this study from Evandela and Swathi Allura, University of North Carolina, said, let's look at factors that help us figure out, is this patient going to respond to topical steroids? So for example, what they found is that if a patient is younger, has a history of food allergies, needs dilation, and has obvious swelling on endoscopy, they're much more likely to respond. Whereas if a patient has a hiatal hernia, part of their stomach coming up into their chest, which is more commonly associated with reflux, they're less likely to respond. So helps us take our patient initially, ask about certain findings that might make us say, well, let's start this patient on steroids as opposed to proton pump inhibitors like omeprazole or Dupilumab, because this makes it more likely they're going to respond. Similarly, this is work from our group when I was at Mayo saying, let's take patients and look at what makes them less likely to respond to a drug like omeprazole. And so we found, for example, that patients who are younger than 36, patients who are not overweight, patients who have a high eosinophil count are less likely to respond to omeprazole. So data like this showing us you're wasting your time starting you on omeprazole, let's go to another drug first. And we've done the same with diet. When we look at diet therapy, for example, we've shown that patients who present with a food impaction are much more likely to respond to diet therapy, and then other findings on endoscopy. So although these things are not written in stone yet, we're making great progress as far as taking therapies as opposed to saying, you have a choice of these 4 things, now saying, well, I would lean towards this one, I would lean toward this one based upon what we're seeing right now. All right. Now, a couple of other things. One is that a lot of people say, well, what if the count is higher? We have more eosinophils in the bottom of the esophagus. Does that mean it's more reflux? And unfortunately, that's not the case. We also know, however, that if you see more obvious signs of reflux, such as what we call esophagitis, ulceration, damage in the bottom of the esophagus, this may lean us more towards reflux or using omeprazole, whereas we talked about having multiple other allergies lean us towards steroids. Other things that influence our choice of therapy include, how urgent is this? If a patient's coming in with multiple food impactions, losing weight, can't swallow, to take months and months to figure out what they're allergic to in foods may not be a good idea. We want to get these patients under control as quickly as possible and use the therapies that are most likely to work, and then worry about later on, all right, now what are we going to do for the rest of your life? So other factors that are important when you meet with your physician or care provider, helping us figure out initially what's the best treatment to start. This is obviously a slide that I don't expect you to interpret because, quite frankly, I have problems with it. But it tells me this is a picture of what the future may bring, and that we may be able to take biopsies and just on that biopsy alone look for certain genes that tell us this patient will respond to steroids or this patient will respond to omeprazole. So we're not ready yet. This is strictly experimental, done in a few labs in the world, but I think the future is looking bright, where between knowing characteristics of the patient and certain biopsy results, maybe even blood results someday, we'll be able to say, this is where we need to go with you. All right. Once we've gotten a hint of what are the options patients may benefit from, then we have to make that decision of what are the available treatments we have and how else we decide. And a lot of this is choosing treatments on the basis of how likely they are to work, and again, how severe the disease is and how much time we have. And we think about the treatment options for eosinophilic esophagitis. We think about diet therapy, because after all, we know this is an allergic disease. It's certain foods that trigger the eosinophilic esophagitis versus medications, omeprazole type drugs, topical steroids, and Dupilumab. Do we want to step up or step down therapy? Do we want to throw the kitchen sink at you, start you on multiple therapies at first, get things under control, and then hopefully start to get it down to one medicine? Or do we want to start on one medicine, try to keep it simple from the very beginning? And then, of course, esophageal dilation is an extremely important therapy, particularly in adults. We'll talk a little bit about, although we need to get the disease under control, having a stricture in scar tissue may not respond to any of these therapies. And so getting the esophagus open, stretching it out so it's a good diameter and things don't get stuck is a very important part of the therapy as well. Now, what about diet therapy? Well, for a long time, diet therapy was not something a lot of people with EoE did, because after all, it's hard. We know the 6 foods that cause EoE: milk, gluten, soy, eggs, nuts, and seafood. Well, for those of you who have friends with celiac disease or lactose intolerance, you know it's difficult for them to eliminate all milk or gluten to begin with. Add 4 other foods to that, and that's really a chore. So many, if not most patients for a long time said, I'm sorry, the diet just sounds too hard. I'm going to go with medical therapy, which is perfectly fine. But times are changing, because after all, we know we're not supposed to take medicines anymore. Pills are terrible, particularly omeprazole or steroids. They're awful drugs. Well, we know that's not the case, but a lot of the press and a lot of your friends will tell you, you can't take those drugs. Gluten is bad for you, right? We all have gluten sensitivity associated with all these other problems. And of course, we're supposed to avoid animal milk protein and go vegetarian now. Now, of course, we know these are not hard and fast rules and general guidelines, but with these trends occurring in the US population, a lot of people are looking back now and saying, well, maybe I should consider diet therapy for EoE. But I think the most important part of the fact of why patients are now turning more towards diet are studies like this. And this was a study headed by Kara Klewer at University of Cincinnati, performed by many of us, a multi-center study in which Kara said, well, let's look at 1 food elimination as opposed to 6. Why should we have to start patients on such a difficult diet? Maybe it's easier than that. And knowing that milk is the most common food allergy in patients with eosinophilic esophagitis and accounts for 45% of people, maybe we can make it simple. And when Kara did this study, and she looked at patients who just eliminated milk, as opposed to those patients who eliminated all 6 foods, and Kara looked at, well, how good are we at reducing that eosinophil count? You can see 34% versus 40, oops, sorry, 30 versus 37. So the numbers are not that different. And so now, if people can say, I'm just going to eliminate milk and I've got a 34 to 46% chance that I'm going to do well just with eliminating milk, that may be a lot more attractive than medications. So, and the benefit of this is not only is it an easier diet to follow, but we're avoiding this. Because we don't have a good non-invasive test yet, such as a blood test or a breath test. And although we have some tests we're working on, like the cytosponge, at this point, the only way we still know whether things are getting better or not is to add a food, do an endoscopy, subtract a food, do an endoscopy. And this is work from Alfredo Lucendo showing in the old days when we tried to figure out what patients were allergic to on a 6-food elimination diet and then add back foods 1 at a time or so, patients were getting up to 10 endoscopies. Well, certainly that's not something anyone wants to go under. So now with 1 food, it may be 1 extra endoscopy if patients respond. So this has been a real revolution. And if you look at many other studies, within what's called a meta-analysis, in which we combine the data from multiple studies. You can see that this shows as well, if you compare a one food elimination diet, OFED, just avoiding milk, to a 6 food elimination diet, or really any other diet, 4 food, or the diet directed by an allergist, it's pretty close. So times have changed with diet therapy, where now this one food elimination diet of milk has become a very attractive alternative to medication. Important to know, though, that if we are successful in getting patients on a diet that works, I feel strongly, as do I think many of my colleagues in the field, that oftentimes we have to give patients a diet holiday. If you take a 20-year-old and say you're never going to be able to have pizza or ice cream for the rest of your life, I think that's a tall order. So as a result, we'll have kids who go to college or they go traveling abroad and they can't control their diet. We'll put them on a medication while they're away. And then when they come home, we'll put them back on the diet. So I think part of the message is we have to make diet more acceptable. And number two, we have patients with EoE have a long life. We have to help them adapt to whatever their situation is, even if diet works. All right. Now, what about drugs like omeprazole? This is another review of all the studies that have been done looking at omeprazole and drugs like that for EoE. And the good news is if you put together all these studies, combine the data, almost 67% will have a response. So this is also better than we thought, that omeprazole can be very effective. So wonderful to have a drug which has been around for that long, which we feel is safe, despite a lot of the side effects people have reported. Many of those side effects, such as osteoporosis and dementia, have been disproven in a lot of recent studies. This is a very good alternative, particularly in patients with EoE who probably have reflux as well. Now, steroids are fascinating, and they're fascinating to me for several reasons. First is that we have so many preparations now. We have eohilia, so the fact that you get a prepackaged slurry already. We have Jorvisa. This is available only in Europe, but will be available in another form in the US, an oral dissolvable tablet. And that for many of us, particularly when we can't get insurance to approve the eohilia, we have budesonide. We take the ampule, we mix it in honey or chocolate sauce or Splenda, make our own solution, we swallow it. And the reason it's interesting to me, because if we look at the data for steroids, it's somewhat all over the place. So here, for example, is the oral dissolvable tablet. On the left, you can see how effective are we at getting rid of the eosinophils. And you can see it's effective in almost 90% of patients. Works very well, this oral dissolvable tablet. But here is a slurry. Now we look at the same data. It's over here, only 60% effective. Now, why should it be that the same dose of a steroid should be more effective in one formulation than another? And this is something we have to study further. Here again, this is the oral dissolvable tablet, which will be available in the United States. Now we're back up to close to 90%, both at 6 months and 3 months. And so part of the message here is that budesonide is very effective. But it's very important to understand what your formulation is. Is it a tablet? Is it liquid? But most importantly, it emphasizes the fact that you have to take this the right way. And when patients take it and then they eat or drink afterwards, it doesn't work. If they don't take it reliably or skip doses, it may not work as well. And so taking it half an hour after breakfast so you don't eat or drink anything and right before bedtime is very important with taking steroids. So steroids are highly effective. Certainly, we could not get by without them, but taking it the right way and perhaps getting the formulation that's going to work best is very important for steroids. All right. Now, of course, the big change has been Dupilumab. And Dupilumab as a biologic has really attacked EoE in a totally novel way. And the way it's novel is that as opposed to steroids, and drugs like omeprazole, which really are sort of blanket therapies, if you will. Steroids have many ways in which they try to control inflammation. A drug like Dupilumab has focused on very specific parts of the mechanism by which eosinophilic esophagitis occurs, and it targets very specific pathways. And by doing this, it is very effective. For example, if we look at the eosinophil count here, 60, I know many of you know that's a high count, and we give patients Dupilumab, it goes down to almost 0 to 3. And you know what? Although the original studies were used it was used in patients who had failed other therapies, it works in every type of EoE patient. In patients who fail therapy, patients who say, you know, I can't take those steroids or those proton pump inhibitors twice a day. Or I'm going to skip days. I know it's not going to work for me. It works in those patients. In patients who've had an adverse effect from one of the other therapies. In patients who say, I just can't do this diet. It's too tough. In all groups of patients with EoE, it is highly effective. Look at these eosinophil counts, 3, 7, 5, 2. So Dupilumab has been a major change in treating EoE. Now, one of the questions is, should we treat all patients with Dupilumab? Should it be a first-line option? This is very controversial within the field, and I'd say still most of us are using it for patients who either can't adhere or failed previous treatment. But I think other indications are opening that some people find this a very attractive first-line therapy. Other things to consider when it comes to therapy are, what about seasonal allergies? And for a long time, we've wondered if you have rhinitis or asthma and it's flaring, is that something that may influence EoE? And I think the data is emerging now that if we look at patients with seasonal allergies, interestingly, there are certain months, particularly when patients are having more symptoms of their seasonal allergies, when their EoE is going to flare up. Interestingly, during the summer, spring, and fall, when all the allergens are in the air, more patients are likely to come to the emergency room with a food impaction. And we also know that medications are less likely to work during this time. So very important when we're giving a therapy to think about what's happening to their other allergies, particularly seasonal allergies, that may be helping the EoE or conversely may cause it to get out of control. And I'll mention something I referred to before, which is also fascinating to me, is why an allergic disease like eosinophilic esophagitis occurs so late in life compared to other allergies. And Jonathan Spergel, pediatric gastroenterologist at Children's Hospital of Philadelphia, has come up with this amazing theory and what he calls the allergic march. And what he thinks happens in patients who have EoE is that they march from, first they get atopic dermatitis, they then get food allergies, FA, they then get asthma, they then get allergic rhinitis, and then they get EoE. In other words, each allergic disease marches and makes it more likely to go on to the next step. Now, obviously, not all patients with EoE have all these other allergic diseases. They may have one or two, but the idea that EoE comes to some degree from having prior allergies that prime or make the esophagus more susceptible to developing EoE in the long run. Fascinating theory. All right. Now, finally, we have to choose treatment. And we talked about this already, but one of the big questions is, what do we want to do ultimately? And I suggest to you, ultimately, we want to get to one medical therapy. We have concerns over the long-term risks of steroids, over PPIs. Is diet hard to follow? The more likely we'll get to one medical therapy that is effective, the more likely we are to have good compliance over a lifetime. But importantly, too, we talked about dilation. We want to get that esophagus open. We want to get it to a certain diameter where we know if it's 16 millimeters, roughly an inch in size, patients are very unlikely to get things stuck that way, even if it's steak or chicken. Now, granted, people with EoE probably always chew carefully. They'll always take a lot of water with their meals. This is something they've been doing for years and years and years. So this isn't necessarily normal, but it's enough. And so the combination of this and this is usually enough to sustain a good long-term response. Because after all, I showed you this picture before. Our ultimate goal is to prevent a patient who starts like this, with an esophagus this wide, to progressing to this over time. Now, how effective are we in doing that? Well, we don't have much data, because part of the problem with EoE is that it's a new disease. And if you're looking at a 20-year-old who's going to have this presumably for the next 60 or 70 years of their life, we don't have that kind of data to know what happens over time. Most of the studies are maybe 2 or 3 years, a snapshot in the life of someone with EoE. However, there is some encouraging data. This is work from Children's Hospital, in which they said, well, let's look at our children and let's see when they grow up to be adults, how does their esophagus look and how does treatment affect that? And if we look at these people and we look at what percent of them develop strictures, narrowing of the esophagus over time, and we divide those people into patients who are not on effective therapy versus patients who are on effective therapy, in other words, medical therapy that's keeping the eosinophils down, keeping their esophagus looking healthy, you will see that whereas close to 100% of people, kids over 20 years, their esophagus stays without narrowing if it's under good control. But if we don't get good control, almost half of them will have narrowing scar tissue 20 years after the disease. So part of the message here is it's very important to not only get patients with EoE under control, but to keep them under control for the long run to prevent that esophageal scarring and narrowing from happening. Now, this is a study we did in adults, and in adults, there may be some improvement, but it's certainly not as good as it is in children. And I think part of the message here is you want to get patients here as children or young adults before the disease has progressed, because maybe when they're adults, it may be too late at that point. So that's why we treat aggressively and consistently with patients. And that brings us to this problem, and that is, do patients really comply and do they get the right care? And this is a study Jennifer asked me to present, which we published recently, looking at treatment patterns and persistent disease in patients with EoE at a large and excellent comprehensive medical center in the country. And what we found is that if you look at after patients get endoscopy, only 60% of them follow up with their gastroenterologist, almost only about 20% with an allergist. A second specialist, less than 50%. Gastroenterologist, only 30%. So part of them, and time to a consultation after a food impaction, months down the line. So our treatment is only as good as long as patients take it and they see their doctors to make sure they stay on top of things. Now, not to say this is the patient's fault. I think a lot of this is our fault, that we don't get patients in, we don't refer patients appropriately. And so part of the message here is that in order for us to have good therapy for people with EoE, there's got to be an important teamwork between both patients and doctors to make sure that follow-up is consistent, that you're seen on a regular basis, that perhaps endoscopy is done every couple of years or so to make sure things are under control, and that the team is there for you when you need it. The idea of saying things are in remission, your esophagus looks great, come back and see me if you have symptoms is not good enough. We have to see you on a regular basis. Finally, a couple of encouraging things. This is a study that we just got accepted. One of the big questions I find from my patients with EoE as well, if this is going to go on for 60 years, am I going to get esophageal cancer? like other diseases of the esophagus. And the good news is we don't see any association between EoE and esophageal cancer. So that's not certainly something I want you to worry about. Finally, maintenance therapy. I think whatever works to get you into remission, get it under control is fine. We think about those side effects, which have been published but not well proven with PPIs. For steroids, our concern of bone loss and adrenal insufficiency, but at least so far, we really haven't seen this in 2-year studies. For Dupilumab, there are some side effects we know about: arthritis, some eye problems, but less than 5%. But look, this is a very new drug. We've got to follow this very carefully. So hopefully what I've shown you today, or at least I think some of the ways we're changing our views on treatment and diagnosis for this patient, how we're assessing patients to decide whether they're doing well or not, and most importantly, data telling us that for all the therapies we have, probably the most important part is proper referral to the physicians who need to be involved to take care of you, and timely follow-up as well. Thank you very much for your attention. I'd be happy to answer any questions.
Thank you so much for your presentation. We really appreciate you going through all of those details and options for everyone. So now is everyone's opportunity to open up the Q&A panel on your website. And while you do that, go ahead and type in your question. We're ready and able to have a great discussion here. So one of the first questions I want to understand is kind of, you talked about how the EoE disease progresses. What are some signs that patients should look for that their disease is progressing?
Thank you, Jennifer. Key question. And I think as far as symptoms go, certainly having more trouble in adults, having more trouble swallowing. So if you notice, for example, the episodes of food sticking, even if they're mild, are occurring more often. If you notice your typical tricks like cutting your food into small pieces, chewing more carefully, is not holding up as well. So I think that's one way. If you feel like your symptoms are getting worse, and certainly if you come in with a food impaction, and that doesn't necessarily have to be to the emergency room, but if you have a prolonged episode of food sticking, particularly when you drink water and the water comes back up, that's a sign of a food impaction, and I think a message you have to see your physician or care provider. On the other hand, I think that's where it's important also to stay in touch with your physician, and where we do endoscopies every couple of years now, because we find that some patients can worsen over time, but yet their symptoms may not show that. So I think the idea of are you progressing is a combination of how you feel, as well as what you're testing every once in a while in the office of a gastroenterologist shows as well. Thank you.
Thank you. So you talked about a number of different types of therapies that people can consider for managing EoE. And one individual followed up that they noticed you had Flovent on the screen. And so they were interested in learning more about the proper usage and options to consider using that.
Sure. Thank you. Well, Flovent is something that we've been using for years. I think I tend not to use it very much now, because the problems with Flovent are if you take it in the form of an inhaler and you spray it in the back of your mouth and swallow it, we know from some studies that a lot of it ends up in the lungs. It's hard to swallow and get it all into your esophagus. Some patients are successful, particularly if they really concentrate on the swallowing. But because our formulations now, particularly in a slurry as well as a prepackaged slurry, and hopefully the oral dissolvable tablet will be available soon, I think our ways of delivering it to the esophagus are much more reliable now than they are with a Flovent inhaler in the past. Thank you.
Thank you for sharing that. So you talked about a number of different treatment options. What do you think are some key considerations that people should talk about with their care team when choosing between them?
Sure, Jennifer. Important question. I think the first question is, do you want to go on diet therapy or take a medication? And there's no right or wrong here. I don't think people should be pressured to do one or the other. They have to choose one which they think is realistic for them. If they can control their diet easily and they're not going to miss certain foods in their diet, by all means, try diet therapy. But you have to know yourself. And if you know you just can't be that restrictive, and having ice cream is an important part of your quality of life, Well, that's okay. I mean, one of the good news about EoE is that even though it's a new disease, we already have so many effective therapies, so you can have a choice at this point. So I think that's the first branch point, diet versus medication. And if you want to follow, if you want to use medication, then we have a choice of those three medications: proton pump inhibitors, topical steroids, and Dupilumab. And then we have to examine some of the finer points, which may lean us one way or another. Do you have eczema and asthma? We know that Dupilumab is an excellent drug for eczema and asthma. So that may be a drug where you get 2 or 3 diseases under control at the same time. Do you have some reflux symptoms? Are you older? Well, that's a drug that may be a case where a drug like omeprazole may handle both your reflux and the EoE. So I think that's where a shared decision between you and your doctor are very important in trying to figure out exactly what the right medicine to start on is. And then, of course, we'll see if it works or not, and do we have to go to another alternative.
You hit on a point there of some of the questions that are coming in, and people are curious, if you choose the medication route, do you get to eat freely, or are you still avoiding food?
Yes. So important, the goal of medication is so that you could eat whatever food you want. There have been a little bit of data on combining diet therapy with medication, which may show it may be a little bit more effective, but I still try to harken back to the idea that I try to get people on one therapy. And if I can get them on one medicine that works, which I can most of the time, then my feeling is they could eat whatever they want. That's the goal of medical therapy.
We've got an interesting perspective here in the questions. We've got a pediatric psychologist here with us today, and they are curious for advice when dealing with people living with EoE and other conditions, including developmental disabilities. Do you have thoughts on which of the types of treatments, or just they're saying that they are often trying to help people learn how to take meds or do food elimination with people that have some oral aversion?
Thank you, Jennifer. Very important question. So I think there are two aspects to this. One is teaching people how to eat slowly, and that's very important. So doctors say eat slowly, but that doesn't really tell you how to eat slowly. So although most people with EoE learn this, there are a couple of tips I tell my patients. First is start every meal with a glass of water, because if you have EoE, then you probably know you're most likely to get into trouble those first couple bites. And that's because you're hungry. You don't chew as well. They put a bigger bite in your mouth. So starting the meal with a glass of water to slow you down and lubricate your esophagus. Now, it also makes you remember, okay, let's start slowly. Let's make sure I chew those first few bites carefully and cut it into small pieces. Putting your fork or your spoon or your sandwich down between every bite and wait until you finish chewing, until you pick it up and put another bite in your mouth, is also very important. Something that we often don't get taught. Drinking a lot of water during the meal is very important. This way we make our food more liquidy, if you will, which goes down through a narrow esophagus more easily. So these are some of the things we talk to patients about to make sure things don't get stuck. Being careful at a party. When you're standing up talking to friends, having a drink, again, you're not going to concentrate on your chewing that well. So these are times you have to think about that. But the other side of this are the psychological repercussions of EoE. And this can vary anywhere from social embarrassment, self-consciousness, why am I always the last to finish, to some patients who develop a real fear of eating. Because after all, who wants to have a food impaction? And we know there's a syndrome now called APFED, avoidance food restrictive intake disorder, where people may have their esophagus may be open and things under control, but they're just too afraid to eat for obvious reasons. We know that the quality of life in people with EoE can be markedly diminished because of this. Again, particularly in teenagers. Boy, what a social issue to have to deal with your friends. So I think instructing patients how to eat slowly, but also taking care of their psychological well-being, particularly if there are these social and quality of life repercussions, is very important to consider when you have someone with EoE.
Thank you very much. So you talked about a form of treatment that is an orally dissolvable pill a few times, and people are curious,
is it available, or when might it be available?
It's not available yet, but I think it will be soon. I'm hoping within the year. It is available in Europe, if you have a friend going over there, but not quite yet in the US. But the Ohelia, which has been approved, the oral viscous budesonide that's prepackaged, certainly is very effective, much easier to take, doesn't have to be refrigerated. So I think that's a major step. For many of you getting the insurance approval can be a little bit difficult, but until we get the oral dissolvable tablet, it's certainly a pretty good substitute.
Thank you. So as you look at the prevalence of EoE, do you see people who are curious, is it increasing the frequency that people are having it, or are clinicians?
So it's definitely increasing. Even though studies have looked at, well, it's because we do more endoscopies, so we see it more. We know that even with all those extra endoscopies we do in recognition of the disease, it's still increasing far beyond that. The latest estimates are that it occurs in 4 in 1,000 patients, and maybe even higher. Well, as a New Yorker, think about how many people pack Yankee Stadium and think about 4 in 1,000. That's a lot of people with EoE. So it truly is increasing. And it makes some sense because all allergic diseases are increasing. We're just a much more allergic society, whether this is because we're too clean, we don't get exposed to certain food antigens and other antigens when we're younger. Some people, as I said, think it's because it's global warming. We have so many other allergens in the air now that these seasonal allergies, as we talked about, are triggering later developments. I mean, just think about it this way. For those of you who are my age, I'm not going to tell you what that is, but how often when you got on an airplane did they tell you you can't eat peanuts because there's someone on the plane with a peanut allergy, or your child can't take peanut butter to school? This was never heard of before. Asthma is increasing, so it makes sense that we would see a new allergic disease as all allergic diseases are increasing.
As we look at different treatments, sometimes people are taking them in the early stages of being diagnosed with EoE. Some people are exploring treatments when they've had significant disease progression. Can any of the treatments that you've discussed actually reverse fibrosis or stop further progression?
That's a question I ask myself every day. And I think it prevents progression. At least our data has shown that. But whether it can reverse disease, we still don't know. And part of the reason for that is because when you think about diseases in which scarring occurs, cirrhosis, for example, fibrosis of the lung, pulmonary fibrosis, this is a process that takes years to occur. And if we look at some of the studies for these other diseases to say, does it reverse? Many investigators don't even start looking until 2 years after they've started a therapy. So unfortunately, it's probably going to be still other studies with much longer follow-up before we know if the disease reverses or not. But nevertheless, I think at least preventing progression of the disease is still a very important goal, and I feel therapies are very effective at that.
Looking at the reverse side of things, when someone is first presenting with symptoms, sometimes children get diagnosed with EoE and are able to verbally describe what they're experiencing. Sometimes there's not a verbal description of what's going on. For those parents that have young children that aren't able to describe their symptoms, what kind of things could they look for, whether they're an infant or a 5-year-old?
Thank you, Jennifer. So important question. And we know that children in general have different symptoms than adults. And the reason they do is because the children, when they get EoE, they're mostly in the stage of inflammation, of swelling. Whereas the adults have had this for so many years, that's when the scar tissue starts. And that's why for adults, the main symptom is something getting stuck. Whereas for children, they feel symptoms are related for that inflammation and swelling. And that can be nausea, vomiting, abdominal pain, chest pain, heartburn. And then there are the very young children who can't verbalize. And so the symptoms you look for in very young children are food avoidance, right? There's some things they just won't eat, or they're afraid to eat, they push it away. Weight loss is something that important because they're afraid to eat, and so they don't get enough calories down. And there's a syndrome called failure to thrive in very young children where they just lose a tremendous amount of weight. So I think food refusal, sometimes with eating, they'll start crying. They may hold their belly. So any kind of excess crying and distress after eating is something that's important. So although it's a little more difficult in children because the symptoms are more vague, non-specific, obviously, these are symptoms that can occur with many other syndromes. Certainly, these are things you'd want to alert your pediatrician to, particularly if your child has other allergic diseases that we talked about, which would go along with having EoE, or a sibling with EoE. We know that if you have EoE, there's a 4% chance one of your first-degree relatives is going to have EoE. So not uncommon that brothers, sisters, parent, child can have EoE as well.
Thank you. While we're talking about kids, let's talk about another child. So we have an individual who's joining us who has cut out dairy. They are using some PPIs, and they're not seeing significant change. So they've started Dupilumab. In this case, they are curious if there's any other treatments, like when you're trying multiple things, like how many different treatments should you try at once? And how do they overlap?
General feeling is, and this gets back to the, thank you for asking that, the concept that I like to get patients on one therapy. I like to keep it as simple as we can. Not only so people are more compliant, but we avoid side effects. There's no such thing as a medicine without side effects. If we would have two medicines instead of one, I think the chances are going to increase. And I feel in almost all patients, in most patients, I'm able to get them down to one therapy, unless they have another reason, like both bad reflux and EoE, that they might need two therapies. I tend not to overlap too much. Occasionally, if I start a patient on Dupilumab, because it may take up to 6 months for the Dupilumab become fully effective, I might keep them on another medicine for a few months before we get to that point. But in general, I want to use one therapy if I can.
Do traditional allergy medicines have any impact on EoE?
So we did a study with Montelukast. Claritin, unfortunately, it was not effective. Now we used a low dose. There are some who say with higher doses it may be effective. Not so clear. Unfortunately, the other allergy medicines, some have not been tested. Others like Chromin have not been tested. So I don't think they're effective. But having said that, we discussed a little bit how keeping control of other allergies, particularly rhinitis and things like that, is very effective. So I do use those medicines liberally for patients with allergic diseases that may trigger the EoE.
Once people are on medication and they're dealing with this, is this something that they're going to take forever? Or is there a chance that they're on the medication for a while and it could go into, I don't know, the equivalent of other diseases saying remission?
So do people or children or adults with EoE outgrow EoE? And at least at this point, we don't think so. I've had a few who had it in childhood and they've been fine for years, and I scoped them and everything looks good. I think in time, we'll probably be able to find a subset of children with EoE who do outgrow it. But at this point, we still go under the assumption that most, if not all, people will need to be on some sort of continuous treatment. Because at least we know from our experimental studies that virtually 100% of people will relapse once we stop effective therapy. Now, will we come up with a magic bullet in the next 5 to 10 years that cures them and they're done? It's possible. But remember, part of EoE is your genetic makeup. People like Mark Rothenberg have identified 4 genes which are different in people with EoE. And of course, you can't change your DNA. So that makes it hard to think that people will outgrow it, but we're hopeful maybe there'll be a small group that does.
If a patient with EoE gets to a point where they can no longer have dilations done because of the damage to their esophagus, what treatments might they consider at that point?
Well, first, I've never had a patient where we can't do dilation. Um, Even those patients who've had perforation tearing a hole in their esophagus, obviously a very severe complication. Once that heals, we can do dilation. Part of the key, though, is that if patients have a very small and narrow esophagus, it has to be a gradual process. And so unfortunately for some of these people will say, well, we can stretch your esophagus, but it may take 2 or 3 sessions. Because of course, if you stretch too aggressively, you run the risk of tearing if you put too much pressure on that esophagus. But I think virtually all patients can get dilation to get their esophagus open, even those with very severe and narrow disease.
Alrighty, I'm scanning through. We still got some great questions coming in here. Alrighty, can you talk a little bit more about the correlation between seasonal allergies and food impactions? For example, the person is actually curious, even kind of a tangent within that question. Is there a correlation between viral infections, such as respiratory infections, and EoE?
Thank you. There have been a few studies looking, showing the seasonality of this disease, that during allergy season, people are more likely to come to the emergency room with a food impaction. There's one study showing that if you do endoscopy on patients during allergy season, when they've been shown to have everything under complete control on a medication, that oftentimes those medications are not working as well during allergy season. So, and it's not in everybody, but in some people, we have to keep that in mind. At least we haven't seen data that viral infections activate eosinophilic esophagitis.
Thank you. Alrighty, let's see. So people are curious what you're looking for to understand if the disease is progressing. Is it just the level of eosinophils when you're looking at biopsies, or are there other indicators that help you determine the progression?
Thank you. And I think it's all of the above. Just as now we don't decide if a patient is remission unless all aspects are under control: symptoms, endoscopic appearance, biopsy, eosinophil count. The same occurs as far as maintenance goes. So if a patient is having more symptoms, if the eosinophil count is up, all these things are very important to deciding has the therapy lost control at this point. As far as eosinophil count, we still take it very seriously, but we don't, as we discussed a little bit earlier in the lecture, we don't rely on it as much. So for example, I'll have patients who have an eosinophil count 20. We try to get less than 15, less than 6, but they feel great. Endoscopically, the esophagus looks healthy. I may not call that patient out of control, and I may just continue their usual therapy. So it's still at every point of the disease, the combination of the way we assess this disease that's important in making decisions on therapy.
I always got some questions about side effects. As you think through the different therapies that you've discussed today, what are some adverse reactions people should consider or watch out for? And can any of those be mitigated by adjusting dosage? Or is it just there's an adverse reaction and you can't use that medication?
Sure, thank you. Most side effects we think are related to the dose related. What we mean is that the higher the dose, the more likely a side effect will occur. Allergic reactions, not so much. However, allergic reactions with drugs like omeprazole are very rare. An allergic reaction with steroids are even rarer because steroids are very good for allergy. With Dupilumab too, they seem to be very uncommon. Can we reduce the dose? Certainly in people who are on these medications, such as omeprazole or on budesonide, we will try to reduce the dose over time. So for example, I will often reduce the dose of omeprazole to once a day and the steroids to once a day. Now, there is the risk that it may not be effective and they have to go back up to twice a day, but we certainly for the long term try to do that if we can. For Dupilumab, I think the data is emerging that it may change from once a week to every 2 weeks. So that's encouraging as well. But we know there are certain limits where you can't go too low with somebody. So we do try to reduce the dose to get the lowest dose we possibly can over time. As far as side effects go, with proton pump inhibitors, there's been a litany of things that have been reported. We discussed dementia, osteoporosis, renal failure. They've talked about heart defects and infections, but it's at least when you look at this, if you look at large populations of people who are on these drugs, these things, if at all, are still very uncommon and often not very different from the normal population. But so we don't do any routine tests for people who are on drugs like omeprazole. We just follow them clinically. For people on steroids, I suspect in time we may do bone densitometry, but at least in 2-year follow-up, we haven't seen a change. The other one we concentrate on is something called adrenal insufficiency. So on top of our kidneys, we have 2 glands called the adrenal glands, and those glands make steroids. We think of steroids as a bad thing, but in fact, your body can't function without steroids. But if you take steroid pills, the glands see that pill and they say, well, I don't have to make as much steroid as I did before because you're giving it to me. And that's called adrenal insufficiency when those glands don't put out as much steroids. And that's something that sometimes we'll monitor every couple of years with a blood test. As far as Dupilumab, there are no tests we're doing to monitor the disease or side effects we're specifically looking for. But like omeprazole, you need to see your doctors regularly and report any potential side effects.
Well, that dovetails into another question. What is regularly? What is the frequency that patients should be following up with their doctors while managing EoE?
Well, this is all over the place. So once I get patients under control, in other words, I've done a biopsy, endoscopy, there's symptoms on a medication, which I know is stable and will work for a while. I'll see them 6 months after that. And then if they're fine, I want to see them yearly. I do endoscopy every 2 to 3 years. I have some colleagues who are more aggressive and they do endoscopy every year. Personally, I don't do that because if I have a 20-year-old, I can't see doing 60 more endoscopies in the life of a 20-year-old. My hope is that I think within the next 5 years, we will have a much less invasive tool for which we can assess disease activity without having to resort to endoscopy.
Thank you. Is there anything else about the persistence of EoE that you would like to share with the audience today?
I think certainly one of the most important aspects of this disease is it's not going to stop you from living to be 95 years old and having 10 children or 5 children. People don't commonly lose weight with this disease. It doesn't involve any other part of the body. It really is isolated to the esophagus. So as difficult as this disease may be, sometimes to treat, oftentimes to cope with, it should not prevent you from doing all the things you want to do for the rest of your life. So very important to keep that in mind.
Thank you. Well, thank you for all your time and for staying on a little bit extra with us today. We really appreciate it. As we also want to make sure we take this opportunity to thank our education partners for their support of this webinar series that includes Bristol Myers Squibb, GSK, Sanofi, and Regeneron. Our next webinar will be about advancing EoE care. We're going to take a deep dive into new guidelines for EoE and the FDA-approved oral therapy option. Please register at apfed.org/webinars and plan to join us on Thursday, March 6th.
And John's a very good guy, and so is Margaret. So you want to tune into that. They're experts in the field.
Absolutely. Dr. Long is going to be doing that webinar in March. And then we recently released a podcast episode featuring Dr. Collins. In this episode, we had a great discussion about the guidelines for childhood non-EoE ages. So we encourage you to visit apfed.org/podcast to be able to check out that latest episode. You can also subscribe to the podcast on Apple Podcasts, Spotify, Audible, and more. It's another great resource to continue learning more about eosinophil-associated diseases.
Yes.
Alrighty. It's also time to mark your calendars for APFED's annual Patient Education Conference. We are headed to Raleigh-Durham this year. We will be down there June 26th through 28th. Stay tuned for more details and schedule and registration. Those details are all coming, but go ahead and mark your calendar and keep an eye out for information there. We hope you'll join us. To continue the discussion started today, we hope you'll also check out our online community on the Inspire Network. you can check it out at apfed.org/connections. It's a great place to connect with patients and caregivers for support. So thank you again, Dr. Katzka, for joining us today. And thank you to everyone that joined us live to watch this webinar as part of APFED's EOS Support webinar series. If you have a question that didn't get answered today, please email mail@apfed.org. I hope everyone has a great afternoon.
Thank you so much for your attention and the privilege of talking. Bye.
Bye-bye.